Hello, hello. In the next few minutes, I'll be telling you a lot about Canada's emergency room crisis. Picture this: a healthcare provider is at a virtual consultation with the patient. The patient on the other side of the room has not seen a family doctor in like 3 years. So they try to describe their symptoms to the provider, but the provider doesn't have any access to diagnostics, to vital readings, or even to electronic medical records. So they try their best, but at the end of the day, when it comes push to shove, all they can say is go to the ER. Like my co-founder here, you go to the ER and you're not there because you're dying. You're there because that's the only place that is open to you 24/7 for you to access. And so you wait 9 hours. That's the average wait time. And this is going up. Let's look at how this looks like in Ontario today. Today, right now in Ontario, there's 2.5 million people that don't have family doctors. And last year alone, there's about 6 million emergency department visits. 1 in 7 of those visits was for cases that could have been treated elsewhere, cases that could have been treated by primary care units, virtual consultations, etc. And each of those emergency department visits are way more expensive than the alternatives, costing $380 minimum. There's three forces that cause this. The first is the structural guarantee. The ER is always open, and it's the only alternative that exists that has this guarantee. Furthermore, the clinical credibility. Virtual consultations, virtual care units exist already today, but without diagnostics or electronic medical records integrations, clinicians just cannot trust it. And the fragmented design. There's digital silos, there's funding silos. All of these things are built independently. Policies move way too slow to connect all of these pieces together. This did not happen by accident. This in 1970s, Ontario started experimenting telemedicine. So this system has existed for a while. The technology has been there, but it just didn't scale even to today. In 1984, the Canada Health Act passed and mandated that ER is guaranteed, but there was no alternatives that carry the same guarantee. In 2010, the Ontario Telemedicine Network expanded to include virtual consultations, but this was limited only to specialists at the time. And today, we're seeing more of this come up. In 2020 COVID pandemic crisis, telemedicine boomed overnight. So we saw millions of visits happening through telemedicine, but still there was no connecting piece with electronic medical records. And finally, in 2023, we see that there's still 40% of Canadians that are going to the emergency room for cases that could have been solved somewhere else. A few weeks ago, Federal Bill S5 mandates that connected care be provided in Canada, and Ontario is pushing forward by investing $3.5 billion in this connected healthcare.
To be fair, Canada did build access. To be fair, Canada did build access. Millions of Ontario residents can now access healthcare virtually. Pharmacy right now can prescribe for minor ailment. Access is expanded. But still, 2.5 million of Ontario residents do not have access to family doctors. Pharmacy can prescribe, but they cannot diagnose you. They do not have access to your medical record system. So when anything is unclear, they ask you to go back to the emergency room. 1.2 million rural Ontario residents travel over 30 kilometers to see a family doctors. And when that's not happening, they ask you to go to the emergency. So this is happening right now. Waterloo Regional Hospital Network, there's a live pop-up. They ask you to go to do not come to the ER. Go and explore an alternatives. So government, initiatives, platforms, they provided access. How about the medical layer? How about the clinical layer? A virtual care provider cannot see what is inside of you. They cannot diagnose you. They do not have access to your medical record. So once anything becomes unclear, and in healthcare, something is always unclear, they ask you to go back to the emergency room. So addressing this problem, what does it unlock? There's $300 million public spending misallocated every year. Right now, $380 is being saved when you successfully redirected one patient, low acuity, from the emergency room. So to recap, Canada emergency problem is not going to go away. Right now in Ontario, the wait time average is about 9 hours. The average is going to cost the government over $300 million annually. We're going to leave you with one question here. What do you think it would take to redirect only 10% of low acuity patients out of the emergency room? Thank you.
Okay, thank you to our second team. I'm trying to think who started our questions last time. Alia, do you want to start this time? If you have a question? Or if you need a minute, you can take a second.
This is a complicated problem here. Yeah, I don't know if anyone has a question on the tip of their tongue.
You want to start? Okay, Andre, go for it.
Okay, what is the real problem here? So, like 9 hours average. So, funny enough, I've been in the ER twice over the last 2 weeks, and my last experience was really interesting. So, I had an issue in my leg that I thought might have been a blood clot. Turns out it wasn't. But 30 minutes of actual patient time took almost 8 hours. Okay. I think the particular case I had, which was a lot of Q&A around symptoms, and then some blood work, and then some extra blood work. They were looking for a certain enzyme that isn't in the standard test that they could do right there, which apparently is not an easy test to do. And then an ultrasound was precautionary, and that took about 20 minutes. I walked out of there thinking that seemed to be, now if it was something else, it would have been high risk. So I was glad I was in an ER. But that seemed to me like the problem I brought to the ER could have been solved elsewhere. 9 hours, that's a pain in the ass for me. But that's not really the ER's problem. The problem you're stating is specifically around overloading the ER in such a way that they're not able to get to the urgent care matters and those people are dying?
That is correct. From Canada.
Because otherwise I'm just inconvenienced.
Yeah, so from Canada Institute of Health Informatics, 75% of low acuity ER visits prefer not to go to the ER. Those are cases that could be resolved outside the hospital environment. Here's the thing. The law guarantees that ER is always open, regardless of your condition. So people do not trust the virtual clinic because there's no clinical layer.
Well, you couldn't have dealt with my problem virtually.
Virtually,
not possible.
yes.
Not
virtually
possible. Yes.
But because there's no trusted diagnostic layer in between yourself.
Well, there is no diagnostics at my house. I couldn't do those tests at home.
That is that is the problem.
Impossible.
Yeah, that is the problem right now, and that is what we are currently addressing. We are building solution around, building clinical layers for you to run diagnostic outside the hospital's environment. It's going to be hospital graded, and it's going to be trusted by clinical. It's currently being used right now in some of.
So the problem you're solving is the non-emergency cases, which will then have the benefit of unloading volume on the ER. Are you solving the ER problem, or are you solving I really shouldn't have to go to the ER?
Non-emergency cases.
So give me not a 9 hour experience, but give me the 30-minute experience that my particular case warranted. You're solving the non-urgent case.
Non-urgent cases, correct.
So you mentioned that virtually there's not enough information or they can't get access to medical records to make a diagnosis. Maybe I'll just dig into that more. One, maybe just confirm that was where you were going with those statements. And two, maybe if you can just give examples of what you see there. Because if I'm thinking of okay, I have a case of strep throat, or I have a case of something where I might need antibiotics, okay, pink eye, you could go to the pharmacy, right? So, but I've like, I'm just wondering if there's a little bit more digging into what's accessible virtually right now, and maybe just give me some examples of like what couldn't be diagnosed virtually and what could be maybe.
Yeah, so let's say Erica has an issue, like common cold, for example. And Erica is like, this is not good. Like, I really don't feel good. I'm going to go to the ER. And then she goes there. Just by going there, even though it's just a cold, she's causing some kind of clog in the system for people that actually do have the real emergencies. And when you get there, it's a questionnaire. They ask you simple questions. They take your blood, like they take your vital readings, and then they diagnose you and tell you, take this medicine or go to this place. Now, the virtual layer exists today. You can virtually try to get a consultation, but they can't do any vital reading. They can't check like your temperature. They can't check like, how are you breathing. They can't, and they also don't have access to how have you been in the last 1 year or the last 2 years. They have no history of who you are. Because of this, they can't say too much, and then they refer you back to the ER, causing that clogging again. And every single time you go to the ER, even though they refer you outside, just because you got there, the cost of just being there, the monetary cost is already like 100 times, like 10 times, or like two or three times more than if you went to like primary healthcare in the first place. So yeah.
Thank you.
One quick question. We're kind of at time, but we can Drew.
Yeah. So you put this into the context of Canada and Ontario in particular. Have there been other jurisdictions that have attempted to solve this problem, and why haven't those solutions been implemented here?
Yes. So we were at New Brunswick a few months ago. The rural community, they are currently they are looking for a clinical layer virtually that can solve this problem right now. In the northern Canadian territories, where there are limitations to primary care, right now they have clinics that are being managed only by nurses. This solution is being sought after right now. They are looking for the same solution right now. Here in Ontario, OTN assisted, but this is only for specialist to specialist care. And right now, the Ontario is spending $3.4 billion to build a connected care. This is a runway for clinical layers. We've got different operators for virtual clinic that are currently looking for this solution right now.
That's all the time we have. Thank you, ABR Detective.